Fitzgerald, who is our treasurer on the Village to Village Board of Directors, and Hillary Simmons, our vice president, are going to lead a conversation about PACE, the PACE program. So Peter, I'm going to let you go ahead, and this is being recorded, and you can go ahead and share your screen with your presentation, or Hillary, whoever wants to do it.
Great, thank you, Barbara. And I will be sharing my screen in just a minute, and I just want to start by thanking you all for this opportunity to perhaps introduce you to a program that you haven't heard before, and if it's a program that you are familiar with, perhaps lead to getting a greater and deeper acquaintance with it. As somebody who works in the PACE world, I currently am the executive vice president at the National PACE Association, and as Barbara said, who is also a real fan of the village to village model and movement. I'm very excited about the potential for these two programs to work together, given the high degree of alignment that they have between the populations that they're caring for and the mission and values that they bring to that care. So I'm going to start our presentation by telling you a little bit about PACE. It might feel like a lot about PACE, but I want to make sure before we go into a conversation about how PACE and villages might work together, that there's a shared understanding of what the PACE program is. After I do that overview of PACE, Hillary's going to offer some comments on how the PACE and villages models align in terms of, as I said earlier, people we're caring for and our goals in supporting them. And then we are fortunate to have a case study from a PACE organization operating in Charlotte, North Carolina, that is working today with the villages there in that community as well. And then we hope to have some time at the end for some audience discussion to get your thoughts on how PACE programs and villages might work together in your communities. So I think we've already heard that the speakers will be myself, Hillary Simmons. Our case study is coming from Brittany Kearney, who works at the PACE program there, and John Ryder, who is the executive director of the Charlotte Village Network. So PACE stands for Program of All-Inclusive Care for the Elderly, and it's an integrated system of care for the frail elderly that has these 4 C attributes that we like to talk about. It's community-based, meaning that care is delivered primarily in a community setting with the intent of maintaining older adults' ability to live in a community setting. It's comprehensive in that it provides any and all necessary care for an individual, and that care is viewed broadly. It could be anything from a home modification to a hospitalization, and I'll talk a little bit more about that later. But you can think of it generally as comprehensive in the sense that any benefits that are provided by the Medicare program or the Medicaid program, and any additional benefits that are specified in the care plan to meet an individual's needs are covered by either directly through direct care provision or through contracted care are covered by the PACE program. PACE is capitated, meaning that instead of getting paid on a fee-for-service basis, PACE organizations get a per person per month payment from the Medicare program or from the Medicaid program, as somebody is eligible for both of those programs. And under that capitation, it's part of what affords PACE organizations the degree of flexibility they have in terms of developing care plans and delivering services. And lastly, it's highly coordinated. It's a highly coordinated, integrated system of care, so that all the different elements of care that are being provided to an individual are aware of each other and are working in concert to help that person have a high quality of life and continue to live at home for as long as possible. PACE serves people who are 55 years of age or older, and it also has a requirement that you live within a defined geographic service area that's specified by that PACE organization. And the reason for that is that PACE organizations operate PACE centers where they provide primary care activities, meals, and therapies. And they want to have a service area that is small enough that the driving time is not that great in order to get to those services. And a typical rule of thumb is we don't want to have an older adult in PACE on a van or being transported for more than about 45 minutes. Everybody who is enrolled in PACE meets their state's criteria for needing a nursing home level of care. Those vary by state, but generally states require that an individual who is going to enroll in PACE and who would have otherwise gone to a nursing home have multiple complex chronic illnesses, as well as dependencies and activities of daily living that they need assistance with. So I think the takeaway here is that people who are enrolled in PACE are not your average, relatively well older adults. They are people who are starting to have an array of complex care needs that are further intensified by the need for functional supports. But importantly, because the philosophy of the PACE care model is to help people live at home, an additional requirement to enroll in the program is that with the benefit of PACE services at the time that an individual enrolls in the program, they would be able to live at home at that time of enrollment. If subsequent to enrollment, there's a decline in health status or other changes that might require that individual to perhaps leave their home and go into assisted living or even go into a nursing home, that is not a reason to disenroll them from PACE. They can stay in the PACE program and we can maintain continuity of care to make sure that they're getting the best care possible. Just a few kind of characteristics of the people who are enrolled in PACE. As you can imagine, the average age is higher. It's about 77. And given that we start out by trying to keep people in the community, even though everybody enrolled in the program could be in a nursing home, at any given point in time, 95% of them are able to live in the community with the benefit of services. Much like the general older population, most PACE participants are women, 69%, with 31% being men. I did want to draw your attention perhaps to the fact that even though our average age is 77, we have a fairly significant group that are in that 55 to 64 year range. So people who a little bit earlier in the aging process are experiencing this complex set of care needs enrolled in the program. And as you could imagine, again, given the frailty of the population, the PACE program is designed to serve. Most of the people we are serving have either 3 to 4 or 5 to 6 dependencies and activities of daily living. That means they need assistance doing everyday activities of life, such as dressing, bathing, transferring, toileting, eating, and walking. And these are on top of what are called instrumental activities of daily living that I know many village volunteers support one another with, such things like going grocery shopping or paying a bill or keeping the house clean. So in addition to those instrumental activities of daily living, PACE participants need assistance with these other activities. The chronic diseases that we see in the PACE enrolled population are consistent with what we see in the general older population. High prevalences of vascular disease, high prevalences of major depressive, bipolar, and paranoid disorders. We know for many older adults, particularly as their ability to get outside of the home declines, and the isolation that comes with that can bring depression, and it's a major issue for the population that we're serving. A lot of diabetes with chronic complications, congestive heart failure, and COPD. Interestingly, about 46%, almost half of the people enrolled in PACE do have some form of dementia. So we see a lot of a high prevalence of people with Alzheimer's disease, and we are able to care for them, keeping in mind that we're able to care for them, going back to that 95% in the home, we're able to care for them and help them continue living at home safely, even as they deal with that condition. The average number of prescriptions is 6, and that reflects a real effort by the PACE program to address any polypharmacy issues. Often people will come into the program, they are seeing several different doctors at the same time. All of those doctors are prescribing medicine for them, and they're not necessarily considering the interactions or duplications. And really one of the first and best things we can do for somebody who enrolls in PACE is to address those polypharmacy issues, which reduces risks of falls and other kinds of complications. And on average, PACE participants are coming to that PACE center about 7 times a month. And while they're there, it may just be that they're coming to participate in an activity or have a meal, but they could also be going to the primary care clinic there, working with a physician, primary care provider, nurse practitioner to address their health needs. Or they might be there getting some physical therapy or all of the above. Right now, there are 144 PACE organizations in the country, and many of those operate more than one PACE center. So in order to provide access to their services across the geographic area that they want to serve, they need more than one PACE center so that they are close enough to where individuals live to make those accessible. And I'm not sure, it's in a later slide, so I'll just mention it now. The total enrollment in PACE programs across the country is about 62,000. So it's still a very small percentage of the number of people, which I think is generally estimated at between 10 and 12 million people in the country who need long-term services and supports. A very small percentage of those people are getting that care from PACE. PACE as a philosophy was designed to honor what frail elders want. It was actually created as a care model in the Chinese American community in San Francisco. The first program, PACE program, was called Unlock, which means peaceful, happy abode in Cantonese. And it was created by that community in order to give their elders an alternative to nursing home placement, to reflect the cultural values of that community. But I think not only that community, the values of most of us, that we want to be able to stay in familiar surroundings. We want to live with as much autonomy as possible. And we want to be able to do that safely according to the maximum possible level of our physical, social, and cognitive functioning. I would say, again, this is perhaps where I see that PACE is so resonant with the origins of the village model itself. Just to illustrate some of the creative ways that PACE organizations support their participants in ways that we really go beyond medical care. I mentioned we're providing a lot of transportation. So in addition to transportation to the center, we might provide transportation for an individual to go see a specialist or to go participate in an activity in the community. We are serving meals. We serve meals at the center as well as in the home. And another favorite example of mine, if you're a dog lover like I am, we can do things like if a participant has a pet that has fleas and we know that that pet is that participant's primary daily companion, we can do things like pay to get the dog dipped and get rid of the fleas so they can continue living in harmony together and not creating any skin conditions from the flea bites of the dog. I mentioned that at the center, PACE organizations are providing therapy. So we have physical therapy, occupational therapy, recreation therapy, and speech therapy. And because we are not part of the Medicare fee-for-service system, we're not bound by the limitations of that program's coverage of PT and OT, which generally in the Medicare fee-for-service system, the coverage is only to get you back to baseline. And once you're there, that program is not going to continue to pay for PT or OT. In PACE programs, we will continue to bring you into the PTOT and really use that as a physical fitness well-being approach to making sure that you are aging successfully and able to do the things that you want to do. I said at the beginning, one of our C's is that we're a highly coordinated program. So all PACE organizations have a PACE interdisciplinary team. It represents 11 different disciplines, 11 different elements of care that go into helping the person live successfully. And this team meets every single morning. They will go over any observed changes in a person's status. So perhaps if an individual is coming into the PACE center that day, and when the driver picked them up, they noticed that their walk was a little unsteady, or they seemed a little bit, not totally tracking what was going on. That driver might actually convey that to the PACE interdisciplinary team, which could trigger a conversation between the physician, who might have just changed a medication and increased the dose, and the physical therapist to get that person in for an assessment. And by doing that, with that high level of coordination, we're able to avoid and quickly sort of cut off a further decline in status and intervene in order to keep that person as well as possible. The funding is capitated, which is just another way of saying we get a per person per month amount. And most people enrolled in PACE today are eligible for Medicare and Medicaid. So it's primarily low income older adults. Even those who are not eligible for Medicare and Medicaid, another 9% are Medicaid only. So those are also low income. older adults. And really, it's less than 1% of the people in the program are Medicare only. And that's for various reasons, but one of those is that the program is difficult for many Medicare only individuals to afford. I'd like to share, and hopefully the technology will bear this out. I did want to share a testimony or an interview with a family member of a PACE participant to give you a sense of what that experience was like for that individual.
I've been taking care of my mother for about 10, 12 years. She has MS, and she started falling a lot, and she was living alone. And I didn't want her to live alone. She didn't want to live with me, but she didn't want to live alone either. Since my mother's been in PACE, it has allowed me to work a normal 8-hour shift because the transportation that comes and pick up my mother in the morning and bring her back. The CNAs are so good with her. I'm able to do a little run around before she comes. The services that PACE provides for my mother is everything that I could ever pray and hope for. And PACE opened and accepted my mother, and they provide medical service, dental service, vision service, hearing aids, whatever she needs, PACE provides. Anybody that wants to take care of their loved one, PACE is the way to go. I can't express to you the joy I feel now that my mother is in PACE.
To find out more about how organizations like yours can help the millions of caregivers like Cassandra, visit the PACE 2.0 website. That's pace2-o.org.
And now I'd like to turn it over to Hillary to talk a little bit about the complementary strengths of the PACE care model and the village model. Hillary?
Great. Thank you, Peter. I'm Hillary with a little help. Sorry if you can go back one. Peter, I think you're driving. All right. Thank you. So I know Peter shared a lot about some of the strengths of PACE and touched a little bit on how we might work together as a village, but we've been at a little help exploring partnership with local PACE providers and have really seen a lot of complementary strengths that have come out of that, and a lot of alignment, as Peter mentioned earlier. So I really do see that PACE and villages can provide complementary support to more holistically meet our older members' needs, especially those who are needing more functional support. I mean, we all see a spectrum of ability in our older adults, and especially if folks are needing more of that support with chronic illnesses. PACE can help out in a way that villages aren't necessarily equipped to do. So villages can often help with support services and social connection, sometimes at a lower cost than PACE because we are using volunteers from the community. And PACE can provide that level of healthcare service beyond what a village and a village's volunteers can appropriately provide and would want to provide, getting into bathing, toileting, some of the personal care and really looking at those ADLs rather than kind of operating at the IADL level. So on the village side, I think do a strong job, hopefully all of us I'm speaking for here, on some of our supportive services, helping with transportation and yard work and handy help and the things around the home and yard that really help our older adults to age well in their homes, to be able to remain independent and with dignity in their homes, and also including that social connection with our volunteers and into the community. Some of that support for those instrumental activities of daily living really shines through with villages and intergenerational volunteers and bringing the whole community together. We also do quite a bit of resource navigation, helping people find the right connections in the community if it's something that a volunteer doesn't provide. And often villages can provide some of the community-based services that PACE also provides at a lower cost by leveraging volunteers rather than staff. But on the PACE side, PACE can support an older adult far beyond what a village's capacity and capability is, because they do have those specialized staff that Peter had just mentioned. So on the care coordination side, helping with chronic illness care, managing and coordinating care, and supporting transitions of care in a deeper way than some villages are able to do. They also have primary care. This is not a role villages would normally take on, right? We're not healthcare providers, but to know that primary care, specialty, OT, PT, speech therapy care, support for caregivers, like the video we just saw, are real strengths for the PACE program. Both do provide transportation, and I know not every village provides transportation, but painting with a broad brush here. But PACE and villages can often get you to a healthcare appointment or to a social activity. So it's great to see some flexibility there. And honestly, I'm sure we've all seen this a bit, but I know we have. There's never too many transportation options. We typically provide 1 to 2 rides per week for our older adults, and that's not enough, frankly. People want to access the community, and the more they're able to, do the social things and get into the community in the ways that they choose, and to have that ready access for folks who aren't driving anymore is so important. And our volunteer drivers are using their own cars, so those aren't going to be accessible for folks who need wheelchair access and things like that. So a lot of great complementary and aligned strengths here. A little bit of overlap, but in a good way, which brings me to some of these opportunities to collaborate. Peter, if you'll advance, thank you. So one way to collaborate is kind of that low-hanging fruit of reciprocal referrals and marketing. We are talking to a very similar group of folks. Somebody could be enrolled in a PACE program and be a village member. So that mutual referral, I think is an easy way to get started with a PACE program, to help connect village members to a PACE program if they're eligible and in need, and the same goes vice versa. And making those warm handoffs is so valuable on the member side. So it's not just, a list of cold calls. So, I'd advocate for getting to know your local PACE provider if you have one nearby. And I don't know if Peter will show that map again. We've zoomed in a bit here, but the other things I wanted to talk about were, getting to that next level of partnership. I mentioned a bit before that often villages could provide a service that PACE might also provide at a lower cost point. So some PACE programs could be willing to partner to help make PACE members into village members, to cover some of the social pieces of care, an extra transportation unit, that kind of thing, to kind of share the care there, because PACE programs are often paying a staff person for kind of each piece that happens to a member, and villages can sometimes do that more efficiently. So one way on a revenue side is that the PACE program itself could pay a village membership for the PACE client. To get even a little bit deeper would be to actually purchase services or do a fee for service type of relationship with the village. This would require some more tracking and some more responsibility on the village's end. If you're in a PACE program's care plan, you share some of that responsibility to get things done. But it's another way to bring in a creative revenue stream into a village for the activities that you're already doing. So, I think there's a lot of interesting collaboration opportunities to explore between PACE and villages. And I'm excited to hear more about an actual case study of this happening. A little help is really in the ideation stages of this. We're getting to know one of our local PACE providers out on the Western Slope in Colorado. And we just launched out there, as did they. So we're all still kind of getting our ducks in capacity in a row to provide the best service we can. But we see a lot of alignment there and are looking forward to partnering in the future, whether it's in a membership way, certainly it'll be in a cross referral way, or if we dive deeper into that purchase services piece. Peter, I don't know if you want to tee up the case study, but I'm looking forward to hearing more about how they're working together already.
Yeah, thank you, Hillary. And that's exactly what I do want to do. I want to turn it over to Brittany and John, who have been in dialogue for quite a while. When I reached out to see if we had any, actual unicorns out there, PACE organizations collaborating with and working with villages, I was so happy to find them and so pleased that they were willing to share their current status and maybe elaborate a little bit on the potential opportunities that Hillary just described. So Brittany and John, I'll turn it over to you.
Thank you, Peter, and thanks, Hillary. My name's John. I'm with Charlotte Village Network. I wanted to mention real quick before we get started that I have a family connection to PACE. My brother has worked for PACE organizations for probably 25 or 30 years. And my mom was actually a member of our local PACE here in Charlotte for about 1.5 years before she passed. And like the lady in Peter's testimonial, the level of care was just super. What a super organization. Everybody in the Charlotte PACE organization is just so caring and wonderful. We were so grateful for all the help they gave my mom. So that was so I'm very familiar with PACE. Like Hillary mentioned, our the things we offer, the village, our village, and PACE they're different, and yet they complement each other. A lot of the things PACE provides, the village doesn't provide, and vice versa. A little bit of background about Charlotte Village Network. We started up in April of 2018 with a limited service area. We now serve the greater Charlotte area. And we also this year partnered with another nonprofit organization called Frankie May. And that organization provides memberships in our organization, Charlotte Village Network, in order to enable caregivers to get some respite care. So the members are actually seniors that folks are taking care of, and we can provide for them companionship visits, so that the caregiver can get out, run some errands, or just even get a little bit of respite, just to do something fun on their own. So that's kind of where we're at. I think Brittany wanted to talk about the next 2 bullet points.
Yeah, so my name is Brittany Carney. I've been with PACE of the Southern Piedmont for about 3.5 years. I'm the Community Outreach and Enrollment Director, and I serve as the president of Charlotte Village Network for about the past year now. But I've been on the board for about 5 years total. So even before I was with PACE, I was still having, some type of decision making with Charlotte Village Network, and just knowing and understanding that our missions are so aligned to keep older adults living at home safely, keeping them supported, getting them the much needed socialization and access to services that they need. Knowing that it's just so right for us to really merge together and work together.
Yeah.
And so one of the things that we've realized is, between PACE and Charlotte Village Network, we're targeting a lot of the same individuals. We work with the Frankie May Foundation as well, and we target the same
Stretch out
referral sources.
to child's
Sorry,
pose.
if someone could mute.
Oops. Oh, sorry.
Ready, mute, please.
Yeah, sorry. Some, let's see. Sorry about that, Brittany. There's somebody in the audience that was making some noises, so can everybody pay attention to their mics? Sorry about that, Brittany.
No worries, very flexible. So yeah, it was just definitely being aligned together and working and partnering together. And Hillary did touch on this a little bit, like what does the opportunity look like for PACE organizations and village networks to combine together? You know, who is going to be paying the annual membership rate? And Hillary did mention it can be paid for by PACE. As Peter said, we are full risk capitation, so we are not limited to what we can spend and what services we can provide to individuals. If we know that there's a need there, we're going to provide and cover that. It could also be paid for by the individual themselves, or even with sponsorship levels. And John, I'll let you just kind of touch on that a little bit of how your model works with community partners to do sponsorships.
Yeah, Brittany. As Brittany said, the membership can be paid by PACE or by the individual themselves. We also have sponsorships. We probably a third of our members we fully sponsor because they're on such a limited income. And that income threshold is, if somebody's gross income is $1,200 a month or less, we will fully sponsor them. Because our full belief is that money should never be a barrier to receiving help from us. And in my opinion, those folks need the help even more because they can't hire outside services. So we also, for income levels above $1,200, we also use the YMCA income scale model as far as discounting our membership goes. So those are some ways that we can help folks, who don't have the means to obtain services. And as I said, they need it just as much or even more so than folks who can pay. So I think we're ready to go to the next slide. Correct?
I've seen a lot of questions about the financial aspects of how the PACE program is funded by individuals, and I'm sure we'll touch on some of those questions later. But as John just mentioned, a third of the membership of Charlotte Village Network is fully sponsored, and with that amount being at $1,200 in the state of North Carolina, if someone is dual eligible, remember the majority of individuals in PACE are dual eligible, but for North Carolina, the Medicaid allowed amount that they keep every month with Medicaid is $1,133. So we are absolutely targeting the same individuals, and none of our services are overlapping. So it really just makes sense. And you can progress to the next slide now. And Hillary did start touching on some of the factors here, but the benefits that myself and John have seen that just really works well in our service area is the following. And John, if you want to touch on these.
Yeah, absolutely. So PACE does provide medical transportation for folks, whether it's to the actual center or to, as Peter mentioned, to doctors, outside doctor appointments or specialists, things like that, hospital, stuff like that. How we complement that, we provide transportation for other things like social events. If someone wants to go shopping, we'll take them shopping. If they want to go visit a friend, we'll do that. And it's in our transportation is individualized. So we, each member has a volunteer who will take them to wherever they want to go, and when they're ready to come home, they take them right back home. And so that's how our transportation kind of aligns. The additional social interactions. Not everybody may want to go to the PACE Center for lunch or socialization. So what the village can offer is and this is what we do. We have different monthly events like lunch and learns, game days where folks will sit around on an afternoon and play board games for 2 or 3 hours. We've also had different outings. There's a exotic animal farm up north of town. We've taken a group up there before. UNC Charlotte has a botanical gardens. We've gone there. Last fall, we went to an apple orchard. That was a lot of fun. They had a wagon ride through the orchard. They have a live music there. They make their own donuts and cider, of course. And every December, we always have a holiday light tour. Some of the neighborhoods in Charlotte just really go all out with their holiday light displays. So we can also have outside events like that for PACE members and village members. Do you want to talk about the other couple bullet points, Brittany?
And as Hillary mentioned, there's no duplication. So they can be enrolled in the PACE program and receive that coordinated care and service for their medical and some social, as well as be a member of the village. And the last thing that I want to touch on, just with the shift and through the pandemic and changes in healthcare and workforce changes, it's really great to be able to depend on the volunteer workforce to get some of this stuff done. As we know, being able to hire personal care assistants and certified nursing assistants and getting them sent out to the home and utilizing contract individuals to do it, it's a lot of coordination. So sometimes it's really, really great to be able to depend on, the established volunteer workforce that, say, the village has already ready and prepared to go out. So that is definitely an opportunity for PACE organizations to then want to partner with the villages as well.
Okay, great. Well, thank you, Brittany, and thank you, John. And I'd actually like to start with the last question here to have some audience participation and ask you to just pop in the chat if there is a PACE organization in your community. And if there is, if you have spoken with them, and we'll just give everybody a few minutes to do that. So quite a few of you are aware of PACE organizations in your communities, and others, I think, not sure. I'm curious, for those of you, if anybody who is aware of a PACE organization in your community, if you'd be willing to share just if you've had any dialogue with them or if they're aware of you. And let me ask Steve. Steve, do we need to take people? Can they unmute themselves, or do we need to unmute them?
Oh, folks can unmute themselves.
Okay.
Peter, I shamelessly plugged the NPA online Find a PACE tool into the chat. So if you're not aware if there's a PACE in your program, it is zip code based, and you can find who would serve your area.
Peter?
Yeah.
Hi, I'm Mary Elizabeth. So there is PACE in my community, and I have spoken to them. In fact, I went through the process where people came out to my house, my mom's apartment, did an assessment. But where we hit a snag was that my mother's not Medicaid eligible, and we weren't able to pay the cost. And so I guess, so that was one of the things in the process was I was trying to figure that out from, from square one. So it took me many hours to kind of go through the city of Alexandria because I had to get her certified as nursing home, it was appropriate, so it was many hours to go through. And then we kind of hit a brick wall. So that was unfortunate. But yes, I was thrilled to have heard about the program, and I do share about it on my website so other people can benefit.
Yeah. Yeah. So maybe just to talk, because I know from many villages, many of your members will not be Medicaid eligible, and that is the population that is mostly in PACE today. And that is largely because of affordability. So if you are low income older adult that qualifies for Medicare and Medicaid and Medicaid are paying the entire cost of your enrollment and participation in the PACE program. If you are a Medicare only older adult, you are required to pay out of your own pocket the equivalent of what the Medicaid program would have paid on behalf of the lower income adult. And that can typically be $3,500 a month to $4,000 a month just for the services side of it. And on top of that, PACE organizations do provide the Part D drug plan coverage for the Medicare only individual. And those plans are expensive compared to other Part D plans. They're expensive because they have no copays and no deductibles, typically no formularies. And due to kind of a quirk in federal law, they don't get the same subsidies that other Medicare Part D drug plans do. So when we sort of look at this in its entirety as a Medicare only individual enrolled in PACE, you might be looking at spending $5,000 to $6,000 a month in order to be in the program. That is a lot of money and many people cannot afford it. It's interesting that it's less than what it would cost you to be in a nursing home. And it is all-inclusive care. So once you have paid that $6,000 a month, you would have no additional care expenses on top of that whatsoever. But your experience, Mary Elizabeth, is not uncommon. And we are at the federal level, we are working on some legislation that would bring down the cost of that prescription drug coverage in the PACE program. Would you be willing to share, where did your mom eventually find care? What did you do?
So I'm still working out the process. I'm actually a live-in caregiver for her. So I've been living with my parents for the last 5 years. My dad passed and I'm still with my mom, but I've been out of the workforce for 5 years. And so I'm in that process of trying to find, piece together.
Yeah.
So I don't know yet. So the answer is she's still at home. That's where we are.
Great. Thank you.
Paul has his hand up.
Please go ahead. It's hard. I can't necessarily see
Thank you,
who's got
Barbara.
their hand up.
Thank you. Peter, there is a PACE organization. This is Paul Sopel with Village in the Heights in Cleveland. The PACE organization here in Cleveland is a pretty sizable CCRC that has everything from independent living to skilled nursing to numerous apartments and also HUD facilities. I casually approached the former president of the organization to talk about this one time. We were business acquaintances, and his comment to me was that as a CCRC, they thought that we were defeating their purpose, which made no sense because the whole idea of PACE was to keep people out of their facilities. But the logic didn't persist with that. Any recommendations there?
First, I'd ask, when did you have that conversation?
Probably about 3 years ago.
Yeah. I'm familiar with that program. That's McGregor PACE, right?
Yes, it is.
Yeah, and I know they did start out as a CCRC. I think they also had a nursing home, assisted living operations, and those were really their origins. And I think for many facility-based care providers, the transition to the PACE mindset of really keeping people at home, even when they are operating that program alongside their other services, is not always a natural or easy one.
No,
I would recommend having that conversation again, because I think things are changing generally in the long-term care world, and partly through the experience of COVID, where we saw that really the least safe place to be was in a facility where you were congregated with other frail older adults. There's some renewed attention at how we can offer people community-based options. And I know that organization in particular, over the last year or so, has really taken a look at the PACE program as being, I'm not going to say it's their only part of their future, but a much larger part of their future. So you might have some different receptivity to it. I know that they have been active in McGregor PACE in encouraging statewide expansion of PACE, so that it's not just the one program there in Cleveland, but available across the country. I mean,
no,
across
it's
the
not.
state.
But also the money for PACE comes from the area agencies on aging, correct?
No, the funding for PACE comes from, on the state level, it comes from the Medicaid department. And on the federal level, it comes from the Medicare department.
Okay, so that being said, have you ever seen anyone go and talk to representatives from CMSD or CMMS?
Would you please explain your acronyms? There's a lot of us who don't follow. Thank
Sorry,
you.
Center for Medicare and Medicaid Services. In other words, is it of any value, and would it look antagonistic, like we're doing an end around, to go to the source of the money and say, you know, this might be something beneficial and more efficient for you?
So I know at the national level, it's the National PACE Association. We are often in touch with CMMS to talk to them about the program, how to make it more affordable, more accessible nationally. And at the state level, I know McGregor PACE and now this sort of broader coalition of providers at the state have been talking not only with the Medicaid department, but also with the governor's office. And the governor in Ohio used a part of the funding that state received under ARPA, where there was enhanced funding for home and community-based alternatives.
Yep.
That went to states, and the state in Ohio is using a part of that money to provide grants to new PACE organizations that want to start developing. And Paul, actually, I do want to acknowledge your question. When you say the money is coming from the AAAs, it doesn't actually come from the area agencies on aging to PACE, but Ohio is one of the few states that designated its Department on Aging as the oversight agency for the PACE program, even though the funding and financing for the PACE services is going through the Ohio Medicaid department.
Okay, so it might be worth talking to the Ohio Department of Aging.
Yeah.
Thank you.
And it looks like, Iris, you have your hand up.
The Village Movement California invited some of us to join in a statewide workshop last week on the lack of a long-term care policy in the United States. California's adopted an action plan to become an age-friendly state. So there's currently an administration that's really interested in looking at these long-term issues. I have to say, as more of a consumer of these services than a provider, the shocking part of that information was how many of us don't have enough assets, even in our very expensive homes, to pay the cost of long-term care.
Mm-hmm.
So for me, the forgotten middle suddenly took on a new reality. And I'm thinking that if we can, we meaning Village Movement and Village to Village Network and villages across the country where there is the capacity to watch these policy issues, can really notice that if the forgotten middle joins hands with some of the very low income households that need assistance, that we really we really have a need out here to develop a long-term care policy that allows people to get the care they need. And I think the PACE model, I'm in the Bay Area, so I'm very familiar with Unlock and what they did with the PACE model. The PACE model is just really a great model. I'm sure it could be improved, but it seems like there might be some really wonderful partnerships that we could build between villages and PACE to utilize that continuum idea where maybe villages really focus on the earlier stages of assistance needed, and then you move more into the higher levels of care with the same population in the same neighborhood. With that, I will stop.
Yeah, thank you, Iris. I could not agree more. And I live a little just to the north of you. I'm up in Sonoma, and I saw there were some questions. Somebody I think asked if there was PACE in Contra Costa County. There is recently the Center for Elders Independence, which is a PACE program based in Oakland, extended their service area up to Contra Costa County. It's difficult, if not impossible, for me to see if anybody has their hand raised. So please just go ahead and unmute yourself and talk if you would like.
Peter, I have a quick question. It's Barbara. So the PACE program in Northern Virginia that I was participant, it had a public-private partnership with Inova. Is that still existing, or are there other examples of partnerships to get PACE programs off the ground? Inova was the hospital system in Northern Virginia.
Yeah, so the PACE program that was sponsored by Inova is not operating anymore. It was replaced by actually a partnership program of Concerto Care and Edenbridge. So Concerto Care is a for-profit entity that operates basically managed care organizations and accountable care organizations in other parts of the country, but is interested in offering PACE. And they partnered with Edenbridge, which is also a for-profit company that's focused on PACE development. So we do see quite a few partnerships around the country. Notably, I would say we're seeing a lot of federally qualified health centers develop PACE programs in communities. We've seen partnerships of home care providers, hospice providers develop PACE. So really, I think it makes a lot of sense in a community to look at how we can combine the existing services there to develop and launch PACE. I do want to ask, I think we have do we have a little bit more time, or are we ready?
Yeah, you're okay. You're okay. Eric Larson has his hand up also.
Okay.
Hi, Peter. I'm the executive director of the new village of Sonoma Valley.
Great.
I didn't know that you were here.
Yeah,
My
well,
question, and we don't have a PACE in Sonoma County. And so I'm wondering, since we don't have, for those of us who don't have a PACE in the area, how do we, is there something we can do to encourage the development of a PACE program in our communities?
Yeah, I will share with you that my understanding is a PACE program just opened in Napa, and they are including at least the town of Sonoma in their geographic service area, since you can get, back and forth between those two places. And there is a program under development that will be located in Rohnert Park. So I guess your geography might be better than mine, a little north of Petaluma. So we're between Petaluma and Santa Rosa. So they are coming to our part of the world. But to answer your broader question, I think it's wonderful if the villages that understand the needs of the older adult community can go and talk to different providers in the community, like the community health centers, like their hospital systems. We also have some PACE organizations that are owned and operated by area agencies on aging. So really, I think if you see and perceive that there's a need for this kind of service in your community and you don't have it, then you can really be a change agent yourself by introducing the idea and sharing with those organizations your understanding of what your community wants and needs.
Thank you.
Another hand raised, Laura Geller.
Hi, thank you very much. This has been really very enlightening. But I have two questions. First is, I'm part of High Village LA, which is a synagogue-based village in Los Angeles, and there is a PACE program nearby us, but most of our members don't want to change their doctors. And what would you say to people about that issue? And the second is, if somebody is living in a older adult facility but not a nursing home and would want to be part of PACE, could they?
Okay, I'm going to answer the question generally, and then I kind of want to bring Brittany into this conversation as well to see what she's experienced with people. But generally, PACE organizations have the option of supplementing the primary care providers that they employ and that work typically out of their PACE center. They can supplement those primary care providers with community-based primary care providers. And if they're doing that, they can offer the option to the participant of retaining their current primary care provider. We often see that even when that happens, once the individual gets familiar with the PACE program and sees the level of access that they have to the PACE primary care physician and the geriatric expertise of that primary care physician, they're often willing to then transfer over. But it's not a prerequisite, and that is something that PACE organizations can work out, but that's not uniformly true either. So I'm curious, Brittany, what your experience has been with people as they consider either giving up their doctor or looking at ways to retain them.
Yeah, absolutely. That has been historically one of the biggest concerns, is that they've been with their doctor for so long. With that impact, we've shifted our model just a little bit to allow, we will treat someone's previous primary care provider as a specialist. And so we will pay for them to go to a return follow-up with their primary care. We will provide all the notes that our doctors have done, but that way they still have that interaction and that follow-up with them. And what we're typically finding, and what we assume that we're going to find, is that they no longer want to go back and see that primary care provider. As Peter said, the level of access, the level of care that they receive, the amount of time our providers can spend with participants. Speaking for our model, and the majority of models are fairly similar, there is a very small participant to provider number, which means that our providers are spending much more time with participants. They're familiar and aware of more than just their medical concerns. They know everything about kind of like the socioeconomic status, caregiver support, what the home environment looks like, what therapy they're receiving, the meals, and how they're getting their food, ensuring that they're getting their medications. And so some primary care providers are like, yes, this is the program that you belong in. You don't have to come back and see me. But we understand that older adults have historically seen the same provider for years upon years upon years. And it can be very daunting for them to think that they have to give that up. So we do give an option for them to do a return visit.
Thank you. That's very helpful. And then the second question, if you're living in a facility but not a nursing home, can you access PACE?
Yeah,
Yes, so they can be living in, I'll let Peter talk to this because all states are different.
No, go ahead, Brittany, because I think your situation in North Carolina is interesting.
So in North Carolina, we are not able to enroll someone if they're residing in assisted living, but we can do so from independent living, family care homes, group homes, or just regular community. There are other states, though, that can enroll from assisted living and can also utilize assisted living for long-term care placement, but North Carolina doesn't see it that way. But individuals do not have to disenroll from our program if they end up not being able to safely reside in the community any longer. Usually we'll see that happens if there's a change in caregiver status, or if a health incident has caused their abilities to completely decline to a point where they're no longer able to safely their needs be met in the community. We can continue to keep them in our program while they reside in a nursing home. They'll still see our doctors, they'll still get their medications from us, we'll still provide therapy and transportation, and they can still come to the Adult Day Health Center. So they don't have to disenroll if their level of care needs change.
Peter, we have one more question. I know that we're running out of time. Eddie has his hand up.
Peter and colleagues, I guess I would just urge, it's not so much a question as a comment, I would urge caution in going about trying to meet with CMS or your local AAA or your local state office on aging, health department, whatever. Villages need to be a little bit more circumspect about what we have to offer and how ready we are to be knocking on doors, asking for money and support. I would encourage those kinds of policy advocacy questions to be posted on our forum. We have a policy forum, and that would be a good place for us to be able to collect information from villages across the country so that we can make some decisions about moving forward in that area. Peter, I don't know if you want to react to that, but that's just my gut reaction.
Yeah, I think where there are opportunities, and we have done this in some communities, I'd say most recently successfully to bring a PACE organization to the District of Columbia, and it hasn't opened yet, but it will be opening in the next few months. I liked the comment from someone earlier around creating age-friendly communities, and I think there is a nice intersection of the work that PACE organizations do with the work that villages do to advocate for more age-friendly communities that you can live in successfully with a high quality of life as you age. And I think maybe, Eddie, I would say coming together around that message is fertile ground, and then you can leave some of the funding and financing conversations perhaps to individual groups, or to adjust those conversations to the particularities of that community and that agency or government.
That could be a good planted question for tomorrow morning's session with the pundits.
The panel of pundits, yes, they could answer this question.
So, lead question. Anybody wants to jump up and do that? We'll have an open mic.
Brittany, any reaction as well?
Well, I just think, bringing awareness to the possibility of PACE being able to come into a community, you're not going to people and asking them to fund it. There's a lot of individuals out there that would like to start PACE programs, and you just have to get the buy-in of individuals, of the states. Obviously, the regulations are there. So just raising the awareness that this program exists as a national program that could help benefit the community.
Perfect, thank you.
Can I add? Is there time or?
I think there is time. I'm
So,
not sure,
I just
Barbara.
I just think that we're a very small village. We're 45 members. We're all volunteer. I don't have standing to go talk to our hospital systems. I don't have standing to go talk to the area agency on aging. And that's where we really rely on Village to Village Network and Village Movement California to take our voices forward on that policy level. And I just want to thank you all for that, because I think what we're doing in our neighborhood is essential. And what we need is your support. I look at our little village and notice how much time we spend on administration. And I think, what if PACE had the room to think about building a village in its neighborhood where it's providing services, and that could be its sort of early intervention as people age in place. I don't know if that would work, but I think that's the creativity we need. We really do need. And this is the first time I've ever heard a conversation where I thought about PACE as even addressing the forgotten middle class who's facing just an inadequate system of care. So thank you.
Thank you. Great comments.
A question. I wanted to know if long-term care programs pay into PACE.
So PACE is paid entirely by Medicare and Medicaid, or if the individual is not eligible for Medicaid, then the individual pays themselves. So I'm not sure I understand Ellen, I believe that's you speaking.
Yes, it
What
is.
the-
My
what the-
long-term care plan will offer home care.
Oh, you're talking about like a long-term care insurance plan?
Yes.
Yeah. Yes, they can. So they can pay PACE. Typically, what the insurance plan will want to do is pay PACE more on a service level. So not just a flat monthly amount, but they'll say to the PACE program, tell me, how many times the person went to the PACE center. Tell me how many physician visits there were. Tell me home care visits. And if the PACE organization is able and willing to itemize those services, then the long-term care insurance plan can pay for those.
Thank you. That's great.
Lori, just talk.
Oh, I'm sorry. Okay. Question. I have a question. Is it traditionally true that the physicians that staff PACE centers are always geriatricians, or is that just sometimes? Because I
think-
know that's true with Edenbridge, and I just was curious.
Yeah, it's not a requirement that they be a geriatrician. There are regulatory requirements that everybody in PACE have a familiarity with and an understanding of care for older adults. So that's pretty loosely defined, but across all of the interdisciplinary team, the regulatory expectation is that you have a higher understanding of older adults' care needs than somebody who had never taken care of them before.
I see. That is rather loose. Okay.
Yeah.
All right.
It's pretty loose. Yeah.
I guess that's a direct sort of reflection of the paucity of geriatricians.
It is. I will say that as a community, as a medical community in PACE, and there's quite a bit of sharing of information, they are looking at, when they look at clinical practice guidelines, they're taking a deeper look to say, was that guideline developed for an older adult population or a general population? And also really looking at plans of care and goals of care to make sure those are reflecting the older adults' wishes and stage in life. So there tends to be a little bit more intentionality, Lori, I would say, across the board.
Right.
On that.
Because I've seen what the program looks like, or at least what they're intending for it to look like in Ward 7 and 8, and I was very impressed. But it's also very geriatrician driven in that particular instance. So I just was curious whether that was across the board in PACE or just particularly true in that particular case. So thank you for the clarification.
And I'm noticing in the chat there's some interest, John, in what you were talking about with regard to the PACE organization, perhaps being able to pay the village, the cost of being in the village for a lower income adult. Can you say a little bit more about that?
Yeah, Peter, I was trying to unmute. Yeah, as I mentioned, that a third of our members are fully sponsored, whether it's by other individuals or organizations or foundations or, through our own organization. PACE is also able to provide memberships in our organization for folks as well. So it's, there's funding available for folks to receive the help they need if they're, on a limited income. So.
Thank you.
So John, just to clarify, you have some members whose membership is paid for by PACE?
Currently, no, we do not. But that is a definite possibility.
Oh, okay.
Right.
we have, I think, exhausted all our questions. Anybody else have any comments, questions? Peter, I'm sure you're gonna make your slides available for everybody. We have them, so we'll share, and the video, of course. And we thank you, and John, Brittany, Hillary, great presentation. And from the seat that I'm sitting, you know, a lot of our villages are struggling with aging villagers, and I think it's a great, you know, accessible, feasible, and as somebody pointed out, $4,000 versus $12,000 for nursing home level care is a huge, you know, difference. So thank you for the great information. We appreciate it.
Thank you
I
all
just
for the
confirm-
opportunity, and enjoyed speaking with you, and hope to continue this conversation down the road.
Thank you.
Thank you.
Thank you.
Thank you all.
Join us tomorrow morning. It's going to be entertaining. 11 o'clock. We have a panel of pundits. So top CEOs of Leading Age, ASA, US Aging. I mean, you know, we're going to hear it from the gurus of the aging industry. So we're very excited. So join us.
And
early.
so you all, it's not a meeting tomorrow, it's a webinar, so you can stay in your pajamas or whatever. You won't be this visible, but you should all get a separate Zoom link for tomorrow and a separate one for Thursday through Zoom. And my sincere apologies to throwing everybody into the classroom like this. I had no idea that I was controlling that. Can you all see that?
I think it's pretty cool, actually.
It really is, but I was sitting there playing around with it like, oh, this is kind of fun. And I had no idea that you all could do it. But I want to commend everybody. I really think today's discussion went great. And I was really nervous about this many people in a Zoom meeting, going to these breakouts, but I think it went really smoothly.
Yep.
I agree. Thank you. And we'll see you all tomorrow.
Yep. See you all
Day
tomorrow.
2. All
Thanks,
right.
everyone.
Okay.
Thanks,
you.
Peter.